Assalamu alaikum. Keeping in view that currently we are having this COVID infection, and this COVID infection's main morbidity and mortality are because of COVID pneumonia, and this COVID pneumonia leads on to an ARDS and acute lung injury, which is the main cause of their ICU admission and a lot of mortality associated with it. So I think we probably need to have a review of what ARDS is, how acute lung disease is caused, and how this is to be managed. So we'll be talking about some case scenario in which adult respiratory distress syndrome can occur, and we'll also be talking about with particular reference to COVID pneumonia, which we have. Now we have two or three cases which will be discussed, and then we'll say that what is common in those cases, and what is the usual cause of their respiratory distress which happens in them. So this is a very common scenario which reports to our hospitals, particularly medical floor is called for that. A 24-year-old lady, she delivered a baby through an emergency lower segment cesarean section. The reason for that was abruptio placentae. She remained febrile, and then she started developing petechial rash, jaundice, and hematuria. Since morning, she was dyspneic with noisy breathing. She was transferred to ICU. At that time, she was having very cold skin, perspiration. Chest was full of crepitations, and chest X-ray showed multiple fluffy shadowings consistent with pulmonary edema. And when we checked her digital oxygen saturation through pulse oximeter, it was 70% at room air, and it failed to improve even when high flow oxygen through nasal mask was given. Now, this is a scenario where a lady underwent a surgical procedure, and of course, this got complicated by some multi-organ involvement, and finally, the last thing which happened was an acute respiratory distress which happened in this lady. Now, this is another case scenario where a 32-year-old previously healthy male, he reports in the emergency room with vomiting, abdominal pain, and distension for past 3 days. He's pale, his pulse is 100 beats per minute, his temperature is 38 degrees centigrade, blood pressure around 100 by 70, respiratory rate was 20 beats per minute, he was jaundiced again. He had a tender, distended abdomen. When investigations were carried out, his total leukocyte count was 20,000 per cubic millimeter, with 90% of them were polis. His ALT was raised 123 international units. He had a blood sugar level running in 234, although he was not previously known diabetic. His urea BUN was 45, which translates into almost 90 to 100 milligram of urea. Creatinine was 2 milligram. Amylase was 456 international units per liter. Now, this is a case scenario where there is the abdominal symptom to start with, and when you check onto the TLC is raised, ALT is raised, amylase, it points towards a diagnosis of acute pancreatitis, and not acute pancreatitis is also getting complicated with acute renal failure, which does happen in because of multiple reasons. It can be a pre-renal failure because of his persistent vomiting, and it can be involvement of the kidney into the disease process. So with this diagnosis, he was admitted on a medical floor, but what happened? On third post-admission day, he became increasingly breathless. He started getting confused. His chest X-ray showed bilateral soft pulmonary infiltrates. Arterial beta gases were done, and there was metabolic acidosis plus hypoxemia. And this hypoxemia again was not improving when he was given a very high flow oxygen through face mask at a rate of around 6 liters per minute. He was then decided that he needs to be intubated, or endotracheal tube was passed, and then he was attached to mechanical ventilator. Now, this is again a scenario in a medical floor where a patient presented with acute pancreatitis has been getting a rapidly progressive distension, and this lead respiratory distress, and then need to add a supplemental ventilatory support. Now, this is the third case. This is a 24-year-old worker who works in an ice cream plant, and he got an accidental exposure to ammonia gas leakage. That is the factory. and he developed severe respiratory distress and went unconscious. He was transferred to hospital by Rescue 1122. During the transfer, he was maintained on ambu bag ventilation and was given supplemental oxygen, and was rushed to ICU straight away. And he was again had to be intubated and put on ventilator. And this was the chest X-ray and the CT scan of this very patient, which is showing bilateral fluffy shadowing. And if you look at the CT scan picture on your right of the screen, you can notice the posterior lower lobe primarily being involved, and it shows both a picture of an air bronchogram where you can see the bronchi, and you can also see some say fluffy shadows suggest consistent with a bit of pulmonary edema, right? Now, this is a recent scenario. He's a 65-year-old male who is diabetic, who is hypertensive, and he returned from a Tablighi Ijtima in Raivan 10 days ago. Where after coming back home, he started having flu-like symptoms with irritation in the throat. He developed a high-grade fever, dry cough, and then started complaining of severe body aches and pains for 3 to 4 days. And he was advised to be isolated, given the current scenario that it may not be COVID infection, and was set to get his nasal swab done for PCR for COVID or novel COVID-19 pneumonia. On third day, he started difficulty in breathing. That was yesterday, and this overnight rapidly progressed to grade 3 dyspnea. So this is a rapid progressive dyspnea in a setting of a flu-like symptoms in a patient who has been into a place where there were a lot of people gathered together, which is not the right thing to do in a current scenario. And on examination, he had a fever of around 102. His respiratory rate was 32. Blood pressure was slightly on the lower side, 100 over 70. His heart sounds were normal. Chest was clear. His digital oxygen saturation was 75% on a 5 liter per minute of a supplemental oxygen. So it was difficult to maintain. So the treating physician decided to intubate him and to put him ventilator after taking all the personal protective say measures with all the guard, so that any of the respiratory secretions for that very patient do not spill over to him or to his hands or do not contaminate him. So this was now an urgent. Fortunately, there was availability of CT scan in the emergency room, and this was his CT scan, which showed again bilateral areas of both consolidation as well as a lot of interstitial edema. Right, so if you notice all the lobes, all the lung, particularly on the right side, you can notice the lateral upper part, and on the both the lower lobes are showing not only an areas of consolidation, but you can also load a lot of interstitial edema into it. Now, these three cases are, say, a manifestation of what we call as in a setting of an acute infection or insult or exposure to gases or exposure to viral illness, leading on to initiation of an inflammatory response. Now, this inflammatory response, as you keep on reading from your third year, that the inflammation is a response of the body to any insult or injury at the cellular and biochemical and immunological levels. This is to benefit. This is to check the insult there and then by walling it off by say contracting the antibodies, and right. But when this inflammatory response overwhelms and as said, does not stop and goes into a perpetual action, that it keeps on continuing, and instead of walling off the insult or inflammation or injury, it starts damaging the host himself. It is there then when we call this as a systemic inflammatory response syndrome. Now, it is actually a constellation of signs and symptoms which are host response to insults. And when it happens in the setting of sepsis or caused by infection, in the setting of infection, then we may call it as sepsis. Now, to label someone that he has initiation of his systemic inflammatory response syndrome or is having sepsis, you need to have two of the following five parameters. So, someone who has been febrile or having high grade fever like more than 38 degrees centigrade, or the other reverse may also be true, that is hypothermic. Both hypothermia or hyperthermia in a setting of say any uh, bacterial, viral or chemical insult would be one of the features of systemic inflammatory response syndrome. Tachycardia, again, there is some degree of some tachycardia associated with fever, temperature, but over and above that, this tachycardia is a manifestation of that myocardium is being inflamed, and patient may be developing some myocarditis, and this may be manifesting as tachycardia. Tachypnea, again, an initial compensatory response to compensate for hypoxemia by increasing the respiratory rate. But when it overwhelms, then of course there would be not only that patient will be hypoxic, uh, he would also have difficulty in gas exchange, and particularly when the carbon dioxide start retaining, then you still develop hypercapnia, and the partial pressure of carbon dioxide in articulate gases may be less than 32 mmHg. And similarly, leukocytosis in setting of bacterial infection, and even leukopenia, because we'll just talk about that when there is an inflammatory response, there is say stimulation of certain phagocytic syndromes of the cells, and this may start say destroying or engulfing their own WBCs or own cells, and there may be leukopenia. So in setting of insult, inflammation or infection, if someone develops hyperthermia or hypothermia, he becomes tachycardic, he becomes tachypneic, he starts retaining CO2, and he becomes either have a very high leukocyte count or a very low leukocyte count. This can be a manifestation of systemic inflammatory response syndrome, or in setting of bacterial infection may be called as sepsis. Now, how it happens, why it happens, this is what is we call as a now being more and more frequently called as a cytokine storm. The cytokine storm is again, it is secondary hemophagocytic lymphohistiocytosis. This the term seems like very complex and very difficult and lengthy one, but I will try to explain that what it is. So in setting of inflammatory response, this system secondary lymphophagocytic lymphohistiocytosis is so far been under recognized hyperinflammatory syndrome. It is characterized by fulminant as well as fatal hypercytokinemia. So cytokines, and this then results in a multi-organ failure. This is most commonly triggered by viral infections, and COVID we know is a viral infection. It occurs in almost 3.7 to 4.3% of sepsis or bacterial infection cases as well. The cardinal feature of this cytokine storm, they include unremitting fever, cytopenias as we just described, and one important feature of this cytokine storm is hyperferritinemia or raised serum ferritin levels. There is pulmonary involvement, and this pulmonary involvement, which also includes adult respiratory distress syndrome, it occurs in almost 50% of the patient who develop this cytokine storm or activation of this hemophagocytic lymphohistiocytosis. Patients with primary HLH have overactive T cells and NK cells, or natural killer cells. These cells cause hyperinflammation, and instead of destroying infected, damaged cells of the body, the host immune system begins to damage patient's own tissues, and organs, and this results in liver failure, results in, say, neurological symptoms in the form of uh, encephalitis or altered conscious level, and of course this then affect the bone marrow as well, from where this uh, cells are being produced. This is this how this is defined. Say hemophagocytosis, this phagocytosis by macrophages, and of erythrocytes, leukocytes, platelets, and their precursors in the bone marrow and other tissues. So what we mean is that their own macrophage, patient's host's own macrophage, they start engulfing the red cells, white cells, and platelets of the their own tissues, and their precursors in the bone marrow as well, and this results in pancytopenias. They would develop leukopenia, they would develop anemia, they would develop thrombocytopenia as well. And similarly, when there is an activation of histiocytes, this becomes a, say, life-threatening hyperinflammatory syndrome, which leads on to release of so many of the cytokines due to highly stimulated but ineffective immune process. Right. So, in setting of COVID pneumonia, cytokine storm profile resembling this systemic hemophagic phagocyte lymphohistiocytic syndrome is associated, and this is related to the disease severity. The characteristics feature of this cytokine storm are it is characterized by increased interleukin 1, 2, interleukin 2 particularly, and interleukin 7. There is lot of release of granulocyte colony stimulating factor, which primary effect is to try to make more and more granulocytes. There is release of interferon inducible protein 10. There is release of monocyte chemoattracting protein 1, macrophage inflammatory protein 1 alpha, and of course TNF, which you are all familiar with. Serum ferritin has been called or labeled as one of the predictor of how fatal this cytokine storm is likely to be. So what we had, or in fact we are having right now, this pandemic of COVID-19, and that started from Wuhan, and it is Wuhan from where we are getting most of the data of these patients, that how did they respond to this infection, and what were the various things observed during the course of their management. So a multi-center trial from Wuhan, China, which included that elevated ferritin. They said that in this elevation in ferritin level can be considered as a marker of severity. And one of their studies showed that those who were put on ventilator and those who survived and those who did not survive, there was a marked difference in the level of ferritin. So those who did not survive, they had on an average of 1300 nanogram per ml of ferritin, whereas those who survived usually had less than 600, or 615 was the average of ferritin level. And if you look at this, there's a highly sensitive as far as this p-value is concerned. And same was true of interleukin 6. In fact, interleukin 6, say, p-value was even further favoring that an elevation in interleukin 6 in a patient who did not survive was quite marked as compared to the other one. So this suggests that the mortality might be due to virally driven hyperinflammation. This has led on to trying to predict that what can possibly be, can we predict that who would survive and who would not survive this infection. And this led on to what is called as H score. H score is stands for calculating the possibility or probability of having hemophagocyte lymphohistiocytic syndrome in these patients. So they calculated H score, and those who had a score of more than 169 had this is sensitive to the tune of 93%, and specific 86% that they were having an underlying HLH or hemophagocyte lymphohistiocytic syndrome. And they also came up with that you need not to have bone marrow done for this labeling or this scoring to be done. And there is an online H score calculator available where you put in all those values, which I'll be showing in a moment. And if you put those values, and you can predict the possible outcome of that very patient, that what are his chances of survival. This is how the clinical parameters are taken into consideration to calculate this HLH. Those who are having a temperature of less than 101, their score is considered 0. Temperature between 101 to 103, they would be given plus 33 score, and those with more than 103, they would be given plus 49. Similarly, if you clinically examine and you find no organomegaly, no hepatosplenomegaly, the score is 0. But if there is either hepatomegaly or splenomegaly, the score is 20 plus 23. But if you have both, liver and spleen both are enlarged, because these are the organs which are involved with the defense systems and involved with the immune systems and production of various activated cells and various proteins. So in any inflammatory response, they tend to get enlarged. So both, if they are enlarged, the score would be plus 38. Similarly, third parameter is looking for the blood counts or cytopenias. Cytopenia would be defined as that if someone has a hemoglobin of less than 9.2, or his white cell count is less than 5,000, or his platelet count is less than 110,000. So this would be considered as cytopenia, any one of those. So if there is only one lineage, either hemoglobin or TLC or platelet, one of them is say decreased less than the given values, the score is 0. But if there is two lineage, that either hemoglobin and WBC both, or hemoglobin or platelet are less, or platelet and WBC both are less. So if there is two lineage, score is 24. But if all three lineage are showing decreased in their levels, then the score would be plus 34. And this is the third one is the ferritin. Ferritin has been considered as an acute inflammatory, say, marker, or this is the one which in any onset of insults or inflammation, it gets elevated. But having a ferritin level of less than 2000 nanogram per ml would be considered as 0. But anything between 2000 to 6000 would have a score of plus 35, and anything more than 6000 would have a score of plus 50. Triglycerides again are considered as a marker of some kind of an acute vascular insult. Less than 133 would be considered as 0. Up to 354 would have a plus score of plus 44, and more than 354 or more than 400 would be considered as more than plus 64. Fibrinogen, again an important factor. Whenever there is inflammation, there is say activation of the system, and fibrinogen is produced, and this fibrinogen finally have to be converted into fibrin and then lead on to fibrosis to wall off that infection. But if this walling off mechanism gets overwhelmed and there's a much more fibrosis, this then would lead on to those organs be getting stiff. And this is what happens in this rapidly progressive COVID pneumonias, that there's a very rapid progression of fibrin, and this fibrin does not, in addition to the lungs getting heavier because of fluid, they also get stiffer because of this fibrin. So a fibrinogen level of less than 250, more than 250 would be 0, right? And similarly, decrease in fibrinogen, which means fibrinogen being consumed in production of, say, is being consumed in formation of fibrin, right? So a low fibrinogen level would be a bad prognostic sign. AST less than 30 would be considered as normal, or would be considered as 0, and more than 30 would be 19. And of course, if and when. You get hemophagocytosis features on the bone marrow. Aspirate, as we already mentioned, that if you take in considering the total score needed to label someone HLH, you may not need this bone marrow being done in all the cases. Now, this is what we said in just that anyone who had a score of more than 169 uh, would have almost 86% specificity that he is having HLH, and having HLH is a bad or poor prognostic sign setting, right? This then brings us to what is ARDS, or adult respiratory distress syndrome. Thus, ARDS is an acute hypoxemic respiratory failure, hypoxemic, following a systemic or pulmonary insult and without any evidence of heart failure, right? So this is hypoxemia you get as a result of multiple reasons. It can be failure of say ventilation, it can be failure of gas exchange, it can be failure on part of lungs getting consolidated, it can be because of chronic lung diseases getting superadded infection. Sometime even heart failure, you have this failing heart lead on to say back pressure, which back pressure then leads on to some fluid coming into the interstitial space, making it thicker and difficult for gas exchange, and then you may have frank pulmonary edema, which one. But if this happens in absence of any heart failure, that's would be called as adult respiratory distress syndrome, or another name given to this is non-cardiogenic pulmonary edema. That we have picture like pulmonary edema, but there is no evidence of any heart failure. So how it presents? It's usually present with the severe dyspnea of a very rapid onset. Someone very comfortable or not that sick, say as far as respiration is concerned, and acutely within a few hours or maybe 24 to 72 hours, if he starts getting severely dyspnea, then this marks a possibility of ARDS developing. Of course, there would be hypoxemia on measuring their oxygen saturation by digital oximetry, and you get their chest X-rays. There would be diffuse pulmonary infiltrates, and then this would lead on to a rapidly developing type 1 respiratory failure. And if not intervened early, this may progress to develop a type 2 respiratory failure as well. What causes it? This ARDS is caused by diffuse lung injury. That's why we call it as acute lung injury as well. And from many, the underlying cause can be direct lung diseases, but there can be non-lung diseases as well, which has led on to what we already talked about, a systemic inflammatory response syndrome, and this systemic inflammatory response syndrome has involved the lung as well. It can happen in some surgical settings as well, we'll be just talking about. And of course, there is a PF ratio of less than 200. Now, the things which can, as we said, that this hypoxemia of rapid onset or dyspnea of rapid onset can be because of insult to the lung directly, and it can be indirect lung injury as a result of systemic inflammatory response syndrome. Direct lung injury, that can, of course, you can yourself say understand that pneumonia can get complicated into ARDS. If you aspirate and your acid goes into the respiratory circuit, it would initiate an inflammatory response, and you may develop this insult leading on to ARDS. Blunt trauma to the lung, pulmonary contusion can start it. Near drowning, of course, a lot of water getting into the respiratory system and reducing that surfactant and leading to lung collapse or alveolar collapse, and this again can result in this ARDS. And as we just had shown a case where there is inhalation of toxic gas like ammonia, this would again put say injure the alveolar membrane or alveolar capillaries and can lead on to ARDS. But more importantly, it's indirect lung injury as a result of activation of systemic inflammatory response syndrome, activation of cytokines, the release of all those things, which again, as we said, would lead on to activation of this fibrin genetic mechanism, consuming all the fibrin and then leading to a very rapid fibrosis developing in the setting. Now, this can happen in any sepsis. This can happen in say, polytrauma or multiple lung injuries, multiple bone fractures. Now, in bone fractures, particularly long bone fractures, it is actually similar to fat embolism. Flail chest can do that. Head trauma can do that. By head trauma, we mean that leading from head trauma, there is cerebral edema, and this cerebral edema then again is one of the initiator for systemic injury response syndrome. It happens in burn injuries. It happens in patients who receive blood transfusions. Now, this is again a peculiar type of an ARDS developing in setting of transfusions, which is again labeled as TRALI, TRALI, transfusion related lung injury. So if someone receives multiple blood transfusions, the transfused blood has contained some say antigenic stimulation, which leads on to an activation of immune system of the host, and this host activation can finally end up in developing of ARDS, or it can lead on to inflammatory response syndrome. We already examined drug overdoses, particularly narcotics can do that. Pancreatitis, we just gave an example, and it does happen in post cardiopulmonary bypass syndromes as well. What are the risk factors for developing ARDS? Of course, if you go onto the list, the maximum patients who develop sepsis maybe if you compare it to those who do not develop, sepsis has almost 4.4 times more chances of developing ARDS. Near drowning is 3.9 times more. Those with congenital immune deficiencies have 3.8 times more risk of developing it. Thoracic trauma, chest wall, 3.7 times. Flu, and this is where we are concerned, almost 3.4 times, sorry, more chances of developing ARDS as compared to say those who don't have it. Pneumonia again 3.3, and then there are of course a lot of other conditions like bronchiolitis, pertussis, pediatric cancers, or gastroesophageal reflux. They all can end up in right, but sepsis and viral infection, they stand out very prominently as the risk factors for developing ARDS. There are certain clinical variables associated with it, that it is likely to happen more in older age. It is likely to happen more in with chronic alcohol abuse. Those who have metabolic acidosis has the more chance of developing it. It also depends upon the underlying illness. The severe is an underlying critical illness, more are likely chances of developing. There are certain scoring systems developed for say calculating the risk of having say ARDS when they are admitted in intensive care units. So there is an Apache score, which is a quite complex system calculation taken into physical say signs, pulse, blood pressure, temperature, as we mentioned, and along with that a lot of other factors. But the more appropriate one was, as we discussed, for the HLH scoring system would be more appropriate to look for. So those with an Apache score of more than 16 have almost 2.5 times more chances of developing ARDS when they are admitted in ICUs. And someone having a score of more than 20 Apache score, their incidence of developing this would be almost 3 times as compared to having a score of less than 9. This is an trying say a diagram showing what happens, right? So if you look at onto the left half of your screen, where there is a normal alveolus and normal the interstitial space and normal capillary permeability, right? So what you can notice on is that I wish I can possibly, yes, okay, that we can possibly get on the marker as well. Now this is your just look at the pointer, that this is the capillary membrane, these are the red cell, these are the junctions of the endothelial say surface of the capillaries, right? This is the interspace. Interspace space does have some say uh, fibroblasts, right? And this is the alveolar membrane. There are type 2 cells over the in the this alveolar membrane, and then there are few alveolar macrophages. Now this is what we have normally, right? Now this is come onto this side of the diagram. What happens is that the process starts from something happening to the capillaries. These capillaries becomes more, their pores get widened, and there is an exudation of products from this capillary membrane. It's a leaky capillaries. Now this capillaries leak, and they lead on to neutrophils get migrated from the capillaries into the interstitial space, and along with that they take some platelets as well. Now these say white blood cells which come over here, they release say right. Now they release proteases. Proteases are enzymes, and these enzymes start getting damaging this cell. Now these collagen fiber, they start secreting interleukin 8, and they also secrete pro collagen. Now collagen, you know, are the say fibers which can lead on to say thickening of the various tissues. They tend to say wall off the infections. Now these protein, released from here, they then start getting damage to the alveolar membrane. Now this alveolar membrane would let, there is this are the type 2 cells which are intact. There's these cells also play some role, but main role is played by entry of some red cells, entry of these say white cell into the alveolar, and from here this activated neutrophils, now they relate leukotrienes, they relate platelet activation factor, they relate oxidants, they release proteases, and and this is the time this alveolar macrophage starts playing its role as well. So it will migration inhibitory factor, then it released tumor necrosis factor, IL, interleukin 8, 6, 8, and then this starts they releasing fibrin, and this is the development of this fibrotic strands into this, which leads on to the damage to the, okay. So this was how a normal alveolar capillary membrane, interstitial membrane looked like, and this is how that an insult to these capillaries as a result of an activation of an say immune system has led on to widening of this space. So this widening would lead on to lesser gas-phase exchange, and there is a very rapidly developing fibrosis of these alveolar say membranes, leading on again the fibrosed alveoli would be difficult to say distend, and of course when they are not distended, the ventilation can't take place, and when ventilation can't take place, the next step, the gas exchange can't take place, and this is what leads to say dyspnea or hypoxemia. Now can this process be reversed? If reversed, yes, you will probably get the say benefit, or patient would recover. But unfortunately, this reversal is quite, say, if there is, it is very slow, and if there is, it is any, it may not be complete. So this is where we now would require that this patient should be uh, put on some kind of an ventilatory support, and the gas exchange is supported through ventilation, and we give a certain sort of say medications to reverse or slow or say get rid of this process which has set in, and if this works, then the patient would possibly start having a normal gas exchange, and he would improve. So what is the natural course of this ARDS? As we had just shown in the diagram, it can be considered in three phases. The first phase is when there is a exudation of fluid and certain along with the blood products from the capillaries into the interstitial space and into the alveolar space, and this lasts for about 0 to 7 days. But this then is started, say, followed by a proliferative phase, that whatever has exuded out, there is a response from the alveolar macrophages and response from the various host cells, and there is release of fibrin, or this fibrosis starts, and this usually takes 3 weeks. And 3 weeks onward, there is so much of fibrosis that the lungs become very, very stiff and heavier, and this fibrosis may not reverse and may end up in a very fatal outcome. The clinical features of ARDS are marked by, of course, there will be a very rapidly developing profound dyspnea. It usually happens within 12 to 48 hours of the initiatic event, which may be, as we said, infection, sepsis, or injury. Patient would start having labored breathing. He would become tachypneic. He would may start showing signs of intercostal retractions and crackles. And when you examine, you may find a lot of crepitations in the lungs as a result of fluid coming into the alveoli and causing this. But it's important that in patients in current setting, the patient who had this ARDS developing or rapidly developing, respiratory developing in setting of COVID pneumonia, this transudation or exudation of fluid is minimal. In fact, there is a very rapid fibrosis, and many a time the clinical examination, like classical ARDS, does not show any crepitations, and they just may appear very, very normal to auscultate. There may not be any crepitation. There may not even be any rhonchi, or any bronchial, say, bronchospasm may not be visible. The mainstay is chest radiography. This would show diffuse or patchy bilateral infiltrates. They rapidly become confluent, and there is characteristically spare the costophrenic angles. You may have air bronchograms, as we just had shown a few pictures earlier. Upper lung zone venous engorgement is distinctly uncommon. That is not seen, which is usually a feature of pulmonary edema developing as a result of heart failure. Heart size is normal, and their pleural effusions usually are not there. This is what you usually get in patient with a very rapidly developing ARDS. You can notice normal heart size. You can note a lot of fluffy shadowing, more so in the lower lobes, and there is a mixture of some showing air bronchograms, but majority of it is showing say fluffy or some ill-defined shadows. If you check their arterial blood gases, of course, pulse oximetry would show hypoxemia, but the mainstay is arterial blood gas analysis. And arterial blood gas analysis, there would be quite marked hypoxemia, which would be refractory to supplemental oxygen. If you check for the arterial partial pressure of oxygen, and its say ratio with the FiO2, or what we call as a fraction of oxygen in inhaled air. Now, just an explanation that what we mean by FiO2 is that in our normal room air, which we inhale and which we keep on breathing all the day long, this is containing 21% of oxygen and almost 78% or 79% of nitrogen, which is neutral, and a few other minor like CO2 or other gases, right? So this is 21%. So when you give pure oxygen by a cylinder through a nasal cannula into the nasopharynx, 100% oxygen, that would be that you are breathing all oxygen and nothing else, and this FiO2 or fraction of oxygen, inhaled oxygen, would be 100%, right? So if you take patient blood sample and take his arterial say saturation, like suppose it is 90%, and you are taking normal room air, so it's 90 divided by 21 would be something, say 4 ratio, right? So when you are PO2 is falling and you are increasing the oxygen saturation, then of course this ratio would be, so the RTL PO2 and inhaled oxygen ratio of less than 200 would be considered as characteristics of ARDS or adult respiratory system. Now, a ratio between 200 to 300 suggests that the patient are having acute lung injury, and they are the one who are likely to benefit from aggressive therapy, and those with the further reduction definitely would have a poor outcome. Now, what we started off with was that it is not the lung only which is having this insult as a result of systemic inflammatory response syndrome. The process is everywhere. The process is involving the myocardium, process is also happening in brain, process is also happening in other tissues, particularly the liver and kidneys and all that. So what happens is that the primary manifestation is as a result of respiratory distress or difficulty to begin with. But as the time passes by, the other organs starts also showing their malfunction, and they would develop kidney failure, they would develop very rapidly developing liver failure, or gut may get ischemic, or CNS symptoms in the form of, say, alteration of consciousness level, or other things may start happening. And similarly, the cardiovascular system insult would lead on to an addition of myocarditis or arrhythmias or SANIA. Now, this is what we call as multiple organ failure. Now, just since we again have to keep on saying that it is a systemic response to the injury, to the insult, to the infection that has led on to, but the first manifestation is into the lungs, but later on there is involvement of other, and this is what is usually the reason of demise or reason of high mortality in these patients. They die of not only simply respiratory failure, they die of multiple organ failure. The whole of the attempt in managing these patients is that you, how quickly and how efficiently you can prevent this multiple organ failure from happening, or if it happens, how efficiently you can probably correct it by further interventions like going for a dialysis, or going for a inotropic support for heart failure, or going for, so this is what is uh, done in the intensive care units, that you look after not only their lungs, but you monitor each and every organ of their body through various parameters, whether it will be urine output, it can be some lab data, it can be ECGs, it can be monitoring. So this all what is required. That's why that these patients cannot be even considered to be managed on a normal regular ward floor, or maybe in a setting where all these facilities of monitoring and of further rapid interventions are not available. Coming on to the ARDS alone, the ARDS, as we said, is primarily as a result of fluid being, say, exuded out into the initial interstitial space and then into the alveolar space. So the main thing which we need to differentiate this kind of picture is from heart failure. So cardiogenic pulmonary edema is the main differential diagnosis, that in patients who are having this dyspnea rapid onset because of a heart failure, whether it is because of cardiomyopathy or myocarditis or mitral valve disease, or in setting of acute massive myocardial infarction, all this would lead on to the left ventricular end diastolic pressure being high, being transmitted to the left atrium, and this left atrium then transmits it to the pulmonary veins, and the pulmonary veins, as a result of back pressure, lead on to transudation of fluid, and transudation of fluid first into the interstitium and then into the alveoli. But what we have just seen, what happens in adult respiratory distress syndrome is exudation of fluid. as a result of capillary leakage. It is not as a result of increased capillary hydrostatic pressure, which is the case in patient with cardiogenic, say, pulmonary edema. Here it is non-cardiogenic. The capillaries get insulted, injured, become more, say leaky, and they leak not only the fluid, but they leak proteins as well. They leak cells as well. And this leakage of proteins and cell is the one of the reason of further say cascade of events which leads to this breathlessness and dyspnea and all those we just described. So how can we differentiate between the two? If you remember that the mainstay in cardiogenic pulmonary edema is into the pulmonary venous pressure getting high or left atrial pressure getting, back pressure getting high. So this can be measured, and if you put in a catheter from the, say, inferior superior vena cava into the right ventricle, and from right ventricle you, say, progress it or forward it into the pulmonary artery and keep it to the most distal part of the pulmonary artery. This is called as capillary wedge, pulmonary artery capillary wedge. Now, if you record the pressure by attaching a manometer with that, the pressure you record is actually a record of the left atrial pressure or a record of what is called as pulmonary capillary wedge pressure. Now, if your patient is having dyspnea as a result of left heart failure, capillary wedge pressure would be high. But if it is not because of that, it is because of the leakage of capillaries, the capillary wedge pressure would not be high. So this is done through what is called as a swan gas catheter. But generally, if the diagnosis is more, say, made on clinical grounds, on other evidence, chest X-ray or CT scan of the chest, so swan gas catheter insertion is not routinely required to either make a diagnosis or differentiate. But in certain cases where there is patient is simultaneously having underlying cardiac insult in the form of an underlying cardiomyopathy or the heart failure, you might have to measure this as well, so that you are more clearly able to differentiate. The management, as you can now recognize, that first is that you should be quite vigilant to note that who are the patient who are likely to develop this syndrome. Anyone undergoing an emergency surgery or any surgical or medical disorder, or developing an acute medical insult like we described pancreatitis, someone going surgery, or someone who has developed sepsis or aspiration or polytrauma patients, they are at risk of, and we just described the risk with compared to not having these conditions and having this condition, how much is the chances of developing this ARDS. So the first is that you should be able to recognize the patients who are likely to develop. Then the next is that we have to minimize the procedures and their complications which are likely to develop it. But you have to, once these patients are admitted in, say, a critical care setup or intensive care, they are also at risk of developing other complications like VTE, like stress bleeding from the gut. They can get further infection from their various lines, their central line, their catheterized, their IV line. So all these can further lead on to an additional source of infection and sepsis, and may even say make the prognosis more poor. You also have to take care of the hospital acquired infection which can happen in these individuals when they are admitted in a setting which is highly say infectious and contagious. And of course while they are being looked after through a ventilatory support, they should also be taken care of their nutritional requirement, because as a result of this systemic inflammatory response syndrome, there is a lot of catabolism going on to produce those proteins. And of course there is additional protein has to be supported in the form of additional nutritional support. The mainstay of their management, particularly of the respiratory component of their disease, is mechanical ventilation, which is usually through you keep on low tidal volume, because high tidal volume setting may lead on to some barotrauma added. You have to give positive and expiratory pressure. There's a lot of talk about that these patients end up being lying flat or in a supine position. They should be ventilated in a prone position, which means they're face down and they are put in a prone position, and this would improve the this ventilation perfusion matching and would lead on to a better ventilation for these patients. Similarly, there are various modes of ventilation. There is a volume controlled and a total control ventilation. There are say pressure support only. We'll some other time we'll talk about those ventilator supports as well. So another is that instead of giving them say high volume, give them high frequency. So so slow pressure, but at a higher rate. So would be better for these individuals. Sometime the lung has been damaged to such an extent that it is no more, because whatever you are supporting through ventilation again has to get exchanged through those same diseased lungs. The alveolar membrane is damaged, there is fluid there, so even if you keep on pushing the air in through the ventilator, how would it get exchanged? So that's where there's a new say concept of type of ventilation which is called as extracorporeal ventilation, right? Extracorporeal membrane oxygenator devices. Now this is what we have is that we instead of ventilating them through say inner endotracheal tube and a machine attached to it, we take the patient's venous blood and attach it to like sort of a heart lung machine, you may call it. And this is the extra cover, and then the oxygenated blood is returned back to this is something similar to what we do in a bypass surgery, right? In a bypass surgery, we take the blood from the say pulmonary artery and attach it to the oxygenator outside or artificial lung, and this then get the gas insert, right? So this would what happened that this would take the lung off the circuit, make possibly it would say recover, and during the lung is on in a recovery mode or a healing mode, we take care of oxygenation through an artificial lung outside. It is being practiced. I'm not sure that whether that sort of arrangement is available in any of intensive care unit over here in Pakistan, but this is quite a frequent mode of management in say well-equipped intensive care units abroad. Right. So you may minimize their left atrial filling, right? Because this would also take a lot of load from the pressure side, which is causing this an additional say transudation of fluid into the interstitial space. Inhalation of nitrous oxide does help. Anti-inflammatory therapies, particularly this talk of this ketoconazole been having a lot of anti-inflammatory effect. In fact, in addition to its antifungal effect, prostaglandin inhibitors, they can also be considered. Some NSAIDs may be of help. Of course, you would be very careful in this setting because they are already at risk of having a GIT bleed, which you don't want to get complicated by an additional NSAID in say adding to the therapy. The course, this mortality is quite high. So in adult respiratory system, 30 to 40% would succumb to their primary insult, despite being having a very good ICU management. And particularly if this ARDS happens in the setting of sepsis, the mortality may reach up to 90%. The major cause of death is, of course, the primary illness which led on to, and secondary complication which already we described in the form of not only the respiratory failure but the multiple organ system failure or sepsis. If they survive, they usually survive 2 weeks, and after 2 weeks, if there is less, I mean, they don't recover. The chances of recovery by with each passing day uh, are getting more and more less, or there would be increased mortality as the time goes by. Uh, of course, it's some even after the respiratory element is corrected and looked after, they may die within few weeks of the other complications of multiple organ failures. Now, this is what ARDS is. We have intentionally not touched on to the more complex part of management, that how these patients are to be ventilated and what are various modes of ventilation. We may sometime, some other time, talk about that. A word about COVID-19 pneumonia, which is the talk of the town, but in fact, talk of the world these days. Now, the current management of COVID-19 is supportive, and respiratory failure, which happens in them, is because of ARDS, as we already described, and that is their major cause of mortality. The treatment of COVID pneumonia, there has been a lot of things about talking that managing it through chloroquine, managing it through azithromycin, managing it through various other, and depending on if they develop a secondary abscess, of course, they may require antibiotics as well. But there is no definite consensus of any treatment. So the role of, say, chloroquine or hydroxychloroquine or chloroquine phosphate and azithromycin, we'll talk about some other time. As far as the respiratory failure associated with COVID pneumonia associated, steroids are not routinely recommended for their management. In fact, they're said that they may even exacerbate the COVID-19 associated lung injury. Immunosuppression, because the main thing is cytokine storm, and cytokine storm we talked about. We showed you a few diagrams where interleukin 1 and 8 and 9 and 7, they are all activated. So there is some say suggestion that interleukin 1 blockade through anakinra, which we normally have been using for other inflammatory condition like rheumatoid arthritis or other connective disorders, can be effective. It has shown some survival benefits in favor of, because it say reduces the inflammation. Then there is talk of the monoclonal antibodies. So there is some randomized controlled trials using tocilizumab, which is interleukin 6 receptor blocker, and this is already licensed for cytokine release syndromes and has been approved for COVID pneumonia. And in China, they treated quite a few patients with this, and sure soon we'll be having results of those trials being published. Then again, this JAK inhibition, which we usually do in certain kind of um, cytopenias, right? And again, this could affect both inflammation and cellular viral entry into the COVID-19. This has been used. All patients with severe COVID-19, of course, should be screened for hyperinflammation using these laboratory parameters we described: HLH, ferritin, decreased platelet, raised ESR, decreased fibrinogen, and all this. H score would be helpful in predicting their mortality. And subgroup of patients where immunosuppression could improve, they should be put on all those, even if some drugs which are being used for trials, as said, they're although not strongly recommended, but steroids are sometime some of the centers are using it. IV immunoglobulin again has been tried, and cytokine blockade through this anakinra, tocilizumab, and JAK inhibition, they are all being tried. Thank you very much for your patient listening. I'll welcome your questions. This, as we said, is an additional lecture, not a part of our routine, say, class course, but everyone has to be familiar what is happening in the town at the moment, what is happening in the world, and being, say, we all being, say, learner of medicine, we have to learn and we have to improve our, say, knowledge for managing what is current and what is to be done. Thank you.